For the sake of time, let's move on to case 3, which is an extensive stage small cell lung cancer patient. So this is a 47-year-old male who's referred to pulmonology for chronic cough and left-sided chest pain exacerbated by deep breathing. His physical exam, he has decreased breath sounds on the left. He's a smoker. He has a 30-pack year history. He has a sputum cytology, which is small cell. I haven't seen a sputum cytology in forever come back small cell, but we can talk about that. His imaging studies reveal a suspicious mass, left upper lobe. The chest CT shows, again, a 4.8 centimeter left upper lobe mass and large hilar node and an invasion into the left pulmonary artery. His MRI shows 3 small nodules. He has a metastenotomy that confirms small cell, and we can talk about the biopsy approach here. And this is extensive stage based on the MRI findings. He has a tumor mutation burden. I don't know if we'll have time to talk about that biomarker in small cell or non-small cell, but nevertheless, it's done. So essentially an extensive stage small cell lung cancer patient. We've had some practice-changing data in the past 6 months on this, but we'll start with the surgeon who historically has been excluded from these conversations about small cell. But you know, there may be a role for surgery in early stage. This is not an early stage patient, but can you talk to us about kind of have you been involved in small cell as a surgeon, and when is that? Who is that patient?
It's a good question. I probably see a case a year, which is like a T1N0 lesion that shouldn't be a small cell, but it is, and he has a pathologist go back and look at it again, and it is. And certainly those patients need an MRI of the brain to make sure it's okay. They need invasive mediastinal, really looking at the nodes, staging. Again, I think EBUS works in there well. And if they're a PET scan and there's really N0 disease, and even the literature now sounds maybe even for N1 disease, but that's a little aggressive. But certainly N0 disease to get a lobectomy and then probably adjuvant chemotherapy.
Okay. This is a small cell case, and I think we all can agree that systemic therapy in some way, fashion, or form to shrink this disease is important. Let's extrapolate, though, to engage the radiation oncologist, pulmonologist here. If this were a non-small cell lung cancer patient with an obstructive lesion, we didn't get a chance to touch on this in the other case. Not a small cell, but a non-small cell. Roles for interventional pulmonary approaches, stents versus radiation. Lonnie, you want to talk just briefly about that?
Sure. These are all palliative approaches, and I think there has been mounting data looking really at the combination of both as optimizing the care of these patients. So patients with initial or early relief of the airway obstruction with a rigid bronchoscope and potentially stenting followed by radiation, I think has really been now well shown to improve at least patient-centered outcomes.
Anshu, your thoughts on this in terms of the role of the radiation oncologist for obstructive lesions for non-small cell? Again, this is a small cell case, but just briefly as a one-off.
Yeah, I agree, and I think that in some of these patients, we typically try to identify whether they're impending obstructions versus actual obstructions, and we typically quote about a 50% success rate of reopening that airway if they're already significantly obstructed, and so we try to catch these patients with impending obstructions. If we're starting to see some post-obstructive changes, we always like to engage our pulmonary colleagues to see if there's a significant endobronchial component. In some cases, if these patients have already received radiation in the past, there might be a role for palliative endobronchial brachytherapy, for example, but we also would also discuss stenting as a way to kind of provide a more robust response in terms of keeping that airway open.